second year neurosurgery resident at Apollo Hospital. So starting with the case. So I'm presenting a case of Mr. X, 28-year-old male resident of Kolkata, manual laborer by occupation, right-handed. The history was taken from the patient and their relatives, and history seems to be reliable. Presented to our OPD with a chief complaint of neck pain since 2 months, weakness of all 4 limbs since 2 months, numbness in all 4 limbs since 2 months, difficulty in walking into 2 months. Coming to the history of presenting release, the patient was apparently healthy until 2 months ago, when a heavy object accidentally fell over his neck while he was working. Immediately following the injury, he lost consciousness for a brief period. On regaining consciousness, he was unable to move both upper and lower limbs. Since the injury, he has experienced persistent severe neck pain localized to the upper cervical region. The pain is dull aching in nature, aggravated by neck movements, especially flexion and extension. And it was partially relieved by cervical immobilization and analgesia. He developed weakness involving all 4 limbs immediately after the trauma. Initially, he was completely bedridden. Over the following weeks, there was slight improvement in the proximal upper limb movements. However, he continued to have marked weakness in all 4 limbs. At present, he has difficulty lifting both upper limbs, is unable to perform fine motor activities such as buttoning clothes or writing, and require assistance for feeding. He is unable to stand or walk without support because of weakness of both lower limbs. He also complains of numbness involving all 4 limbs. The sensory deficit is more pronounced over the left side than the right. He reports reduced appreciation of touch, pain, and temperature. He also complains of stiffness involving all 4 limbs, which progressively increased after the injury. There is no history of bowel or bladder incontinence. There is no history of any cranial nerve symptoms such as diplopia, dysphagia, dysarthria, facial weakness, or hearing loss. There is no involvement of bowel or bladder involvement. There is no any visual disturbances. There is no any cerebellar symptoms. No history of any fever or recent weight loss. There is no past history of diabetes mellitus, hypertension, no history of tuberculosis, no previous spinal surgery, and no bleeding disorder. Personal history: patient takes mixed diet, no history of any addiction, normal bowel and bladder habits, and patient is self-voiding. Family history: there is no similar illness in family members, no congenital cervical spine disorders, no hereditary neurological disorders. So with this, I complete the history. So summarizing the history. So this 28-year-old male presented to OPD with a chief complaint of following a cervical injury, secondary to the falling of heavy object to his neck while working, presented with the complete weakness of all 4 limbs with sensory deficits. The positive history findings we had: he has a sensory loss all over the 4 limbs, motor loss, unable to difficulty in walking, unable to hold grip, unable to perform his day-to-day activities such as eating, combing. Patient was self-voiding. There was no history of any fever, or there is no history of any tuberculosis. There is no history of any dysarthria, dysphagia, or diplopia. There is no history of any cranial nerve deficits. There is no history of ataxia. But there was a difficulty in walking because of the weakness of the lower limbs. So can I move on to the examination, sir?
No, I'd like to ask a question, please,
Yes.
Dr. Gerber here. Can you hear me?
Yes, sir, I can hear you.
When he had the injury, was he
Sir,
tetraplegic or tetraplegic, and did he improve after the initial injury?
yes, sir. He was completely quadriplegic immediately after the injury. The injury occurred months ago. And for the first few weeks, he was bedridden. And after that, he slowly gained some power.
Right. And why didn't he seek medical advice at that time?
Actually, he sought medical advice, sir. He was actually advised to undergo surgery, but they were not willing to go for surgery. They were trying to go for a conservative management.
So he was admitted to a hospital, had investigations done at that time. Is that correct?
Yes.
Yeah. Okay, but he slowly, with bed rest, he slowly improved, huh?
Yes, sir. He slowly improved, but not completely improved. He continued to have a weakness. He continued to have a sensory deficit.
And pain?
Yeah, he had a cervical pain, sir, which was non-radiating in nature, was non-radiating to any of the limbs. There was no signs of any radiculopathy. He just has a upper cervical region pain with the lower occiput pain also.
Fine.
He also
Okay.
has a numbness and heaviness in the limbs.
Fine. Okay. As far as I'm concerned, you can move on now to
Okay. I just want to make a comment. When you are telling the history, you have to use the patient's words actually. Like you have written that there was loss of pain and temperature sensation. So what the examiner will want is that how the patient presented these symptoms. That whether in the patient's language you have to tell without using these terms. Okay, that he was feeling contact with the clothes, how he felt. It felt less touch, and if any other contact with the bed sheet or the clothes like that. Okay.
Yeah, I
Hello?
agree. I think
Yes.
when it comes to the history is what the patient tells you happened to him.
Yes. Yes.
And what was the object he was hit with? Did he say?
So he said some cement slab or something.
Right.
Not
So
exactly.
you should mention that. And what was his? He was working there at the time. Was he walking past it?
Sorry, sir.
Was he working there?
Yeah, he was working there.
So you say he was an employee working in a building. He's on the back of the head, back of the neck, by a cement slab.
Mm-hmm.
Okay.
So was there any external injury?
No, sir. There was no any external injury.
Okay. So from history, what are the anatomical substrates which you feel is involved?
From the history, since the pain is in the upper in neck region, we first of all localize it to the neck region, probably to the cervical spine, or to the, or let's say he's also complaining the pain above the neck, like around the base of the occiput. So we can also localize it to the CV junction.
Yes. And from the weakness?
From the weakness, sir, since he has both upper limb and lower limb weakness, so it's most probably it's a high cervical cord injury because involving all the four limbs. There all the loss of sensation in all the four limbs also, and weakness in all the four limbs.
Yes, yes. So both corticospinal and spinothalamic tracts.
Yes, sir.
Are involved.
Spinal and spinal tracts are involved.
Okay.
Appointment. Zoom meeting करा Zoom meeting.
You can proceed.
Moving on to the examination. Before examination, patient consent was taken. And complete Sorry, sir.
Yeah. Yes, carry on.
So before the examination, patient consent was taken. Complete privacy was given to the patient. On general examination, patient was conscious, cooperative, and oriented. GCS was E4, B5, M6. Pulse rate was taken in right forearm, right radial artery, 78 beats per minute. BP taken in right arm, 110 by 70 mmHg. Temperature was 97.6 degree Fahrenheit. There was no pallor, no icterus, no cyanosis, no clubbing, no pedal edema, and no lymphadenopathy. Coming to the local examination of the spine, one inspection, there was no scoliosis, no kyphosis, no torticollis, no visible deformity over cervical spine, or no neck swelling was visible. Also, there was no any mark of any external injury. Coming to the palpation, there was no local tenderness over upper cervical region. Neck movements were restricted due to the pain. Range of motion, flexion was restricted and it was painful. Extension was also restricted and it was painful. Rotation mildly restricted. Lateral bending was also mild restricted. Coming to higher mental function, patient was conscious and alert, fully oriented to time, place, and person. Memory was normal, speech was normal, intelligence appropriate for age, and there was no cognitive impairment. Cranial nerve examination, olfactory sense of smell normal bilaterally. There was no any optic nerve symptoms such as visual acuity was normal, visual fields were full, there was no defect. Fundus examination was done, which was normal. Pupils were equal and reactive. Third, fourth, and sixth. There was a full range of motion in the extraocular muscles of the eye. There was no diplopia, no nystagmus. Fifth, trigeminal nerve sensation were intact in the V1, V2, and V3 distributions. Muscles of mastications were normal. Cortical reflex was present. Facial nerve, there was no any facial deviation. It has a symmetrical facial movement, no facial weakness. Coming to the eighth nerve, hearing was normal, release was positive bilaterally, and reverse was localized to the center. 9 and 10th cranial nerve, palate elevation was symmetrical, uvula was in central, and gag reflex was good. Spinal accessory nerve, shrugging of the shoulder was normal, which is tested by the trapezius, and the hypoglossal nerve, tongue was central in position, and there was no wasting of fasciculation or protrusion. Coming to the motor system examination, bulk. Bulk was normal in all four limbs. There was no muscle wasting. There was no fasciculation. Tone. There was an increased tone in all four limbs. Lower limbs more affected than upper limbs. Power. Upper limbs. Shoulder abduction has a power of 3. All elbow flexion and extension also has a power of 3. Wrist flexion extension also has a power of 3. Hand grip were reduced bilaterally. To the lower limb, hip flexion, the power was 3 by 5. Knee extension, the power was 3 by 5. Ankle dorsiflexion, the power was 2 by 5. EHL weakness was there, was 3 by 5. And plantar flexion was also 3 by 5. Overall quadrant paresis was present. Reflexes, superficial reflexes, abdominal reflex was diminished, cremastic reflex was absent. Plantar response was bilateral extension. All the dependent reflexes were exaggerated. Biceps 3+, triceps 3+, shoulder 3+, knee 3+, ankle 3+. And the pathological reflexes were also elicited and it was found to be positive. Hoffman sign was positive and ankle clonus was also present. Coming to the sensory examination, the pain was reduced below approximately C2 derma 2. Temperature was also reduced below C2 derma 2, and good touch was also reduced below C2 derma 2. Fine touch was largely preserved. Vibration senses were normal. Joint position sense was also normal. Cerebellar examination. Finger nose test was done, found to be normal. Wheel sim test was also normal. This diode glucokinesium were absent. No intentional tremor and no rebound phenomena was seen. Gait was a spastic type of patient was walking with support or walking aid and difficulty with tandem walking because of the spasticity. There was no signs of any cerebellar ataxia. Respiratory system bilateral equal chest expansion, normal vesicular rhythm, bilateral equal air entry, and no added respiratory sounds present. Cardiovascular system S1, S2 was normal. No added heart sounds were heard. Abdomen was soft, not tender, no organ and bowel sounds were. So to summarize the case, this is a 28-year-old right-handed manual laborer with a history of high energy cervical trauma caused by a heavy object falling on the neck, followed by transient loss of consciousness and immediate quadriparesis. On examination, he was conscious with spastic quadriparesis, bilateral upper limb power 3 by 5, bilateral lower limb power 3 by 5, bilateral ankle dorsiflexion 2 by 5, bilateral PHL 3 by 5. Sensory loss involving all four limbs, left greater than right, and preserved bladder function. So the findings are suggestive of post-traumatic upper cervical spinal cord compression secondary to C1C2 instability, resulting in incomplete cervical spinal cord injury.
Can I stop you there? Just
Yes,
going back to the examination. Did you test his jaw jerks?
sure that's
যারা দীর্ঘদিন ধরে অপেক্ষা করছিলেন তাদের ভালো উপস্থিতির জন্য কোন তিন রাশি সেটা নিয়ে আলোচনা করবো। এই পুরো ভিডিওটা খুব মন দিয়ে
No, the reason I say that is how can you say
think,
so you didn't
I missed the jaw reflex.
সবথেকে বড় কথা হলো তারই
his jaw reflex?
কিন্তু একসাথে কাজ করছে। কি যেমন
others have to
What about
please keep
deltoid?
their
We
microphone on mute.
কতটার
I request others to please mute their microphones.
Yeah. Can you hear? I mean, basically, I don't know from the sensory point of view, which is not very what's the word? Not very objective. Yeah, I don't know how you can say this is a C1, C2 lesion. If you said C1, C2, what would happen to the jaw jerks? Would they be normal, brisk, absent? Jan, can you hear me?
yes, sir, I can hear you.
What happens to the jaw reflex?
Jaw reflex should also jaw reflex should be present, sir.
Yeah, it would be normal.
Yes, sir.
Okay. So you'd have a normal jaw jerk. What's the importance of that? I mean, if you have a normal jaw jerk.
A normal jaw jerks, it means that we have that intact
What's the reflex arc of the jaw jerk?
those sensations are carried by the trigeminal nerve,
Yeah.
and the response is
Aren't the jaw jerk will be it either will be absent or the normal? If it will be exaggerated, that means there is an injury above the cord. Means it's either in the brainstem or above. All right.
Yeah. Or can of a CV if it's CV junction anomaly. I'm getting lots of feedback from
You
people.
get it, Dr. Anand?
yes, I get it. We are trying to localize the lesion below the brainstem.
Yeah. Okay. So I mean, I think it's very hard to make all the conclusions on the basis of the examination and the history. Yeah, I agree. I don't know. I'm getting a lot of cross talk
Dr.
feedback
Christopher, can you
from other
please mute
people.
all those people? Can you please mute those who are not contributing to the academic? Please just mute, and when you want to contribute, you can unmute yourself.
Right? Can you? I just think if you go to your summary slide. You see, your last point. I agree with the first sentence, upper cervical cord, but I don't know how you can say from the examination and the history that C1, C2 instability. That only comes from further investigation.
From based on history, there was a history of trauma. And the second thing was that the patient immediately has a quadriplegic, but there was some improvement after some time.
Sure.
And there was a sensory loss, means below the C2 dermatomes. And
yeah, I think from your history, you can only say there's a suggestive of a
cannot
high
say it a
cervical
def lift.
spike.
Yes, sir.
Yeah, you can't don't mention C1, C2 instability.
Right.
Because people are going to ask you on that. You say it's a high cervical
ছেড়ে দাও
spine
ওকে, আমি
injury.
ভেতরে চলে যাচ্ছি। ওকে ছেড়ে দাও, আমি ভেতরে চলে যাচ্ছি। যাবে না।
Okay.
Say it's a for high cervical. Agree, sir.
Yeah, and incomplete cervical spine injury. Yeah, spinal cord injury.
Anand,
Yes, sir.
you mentioned whether the patient was wearing a cervical collar and how did you test for the neck movements?
Yes, the patient was using a soft cervical collar intermittently. So with I asked the patient to slowly flex the neck by keeping my hand on the support at his jaw while he's moving, and asked him to stop if he feel a severe pain. So with a slightest flexion, sir, he told me that I have a neck pain, and since I was also aware that he has a history of injury, so I didn't ask him to flex much.
So when you are suspecting a high cervical or a CV junction injury, you should mainly he should do active movements till he is pain, and better to avoid flexion.
Yes.
And ideally he should do a heart or a Philadelphia collar.
Sir, can I make some comments? Sir, here actually the presenter has presented nicely, but schema of neurological examination is not maintained actually. So in the neurological examination, there are first of all higher mental function, then cranial nerves and motor system examination. Also, there are ups and downs there, and then skull and spine should be examined at the last. And when you suspect neck injury, you should not do the neck movements actually. And
Right.
also there are when regarding your jerk examination, deep tendon reflexes, when there is presence of ankle clonus, that means that ankle reflex will be 4+, it will not be 3+. Presence of clonus is a 4+ reflex. And with another point is that with a upper limb power and lower limb power of 3/5, how can you comment on cerebellar signs properly? It will be difficult to do finger nose test and heel shin test with barely 3 power actually.
Of the and also the weight.
And also with while examining the respiratory system in high cervical cord lesion, we are interested in respiratory rather than respiratory rate. We are interested in respiratory pattern. Is there in any paradoxical respiration? any diaphragmatic weakness. And we are also interested in single breath count
Right.
rather than expansion, actually. These are some
Single
of the
breath
points.
count
Yes.
is
Single
very
breath count
important.
and is there any
Respiratory
paradoxical
pattern.
breathing? Yes, that is
So
important.
that is
And
also
also you have to examine for the trigeminal nerve properly regarding corneal reflex and then especially jaw jar, and also loss of sensation in the upper part of the face.
Face, correct.
And you have not mentioned the power on whether right side or left side. Is there any asymmetry, or it is symmetrically equal on the both the sides? Power, motor
And it
power.
was symmetrically equal on both the sides.
Okay.
The sensory was unequal. Sensory has left
Okay.
side.
And you have examined all corneal reflection, all everything was normal.
Yes, sir. Yes, ma'am. Corneal reflex was wrong.
Anand, why is trigeminal nerve testing important in this case?
Yes, sir. Because with that we can localize the lesion below the brainstem.
No. Suppose it's a high cervical cord lesion. So what is the importance of trigeminal nerve test?
Dr. Anand, you being a neurosurgeon, what are the nucleus of trigeminal nerve? Trigeminal nerve and facial nerve are two nerves that are going to be very important when you deal with a CP, with a high cervical cord lesion. You have to know the trigeminal nerve nucleus. So what are the nucleus of trigeminal nerve? If you know that, your answer to this question that doctor is asking, you'll be able to answer.
Oh, the important thing is, sir, the important thing is that in trigeminal nerve, one should look for there are three tracts: sensory, motor, and the mesencephalic nucleus, and descending tract of the trigeminal nerve, which will be impaired in a case of your upper cervical cord lesion. This is number one. Number two, you should also look for any Horner syndrome or not. And number three, very important in a high cervical cord is the nystagmus. Medial longitudinal fasciculus actually comes down up to the level of the C2. So this is the three things for the high cervical cord one should look for, and spinal accessory also an increase. Jaw jerk is very important to rule out any lesion above the level of pons. If it is exaggerated, then you can think about the quadriparesis from some other reason. So this is the only thing I like to mention here.
I fully agree with the previous questioner that any unwarranted movement of the neck is not at all desirable, especially when you're suspecting a C1, C2 dislocation. So flexion of the neck may have been avoided in this particular case. And secondly, along with the counting, breath holding, the time for breath holding should also have been noted.
Yeah, I just say I would agree with that, but I think that what I do in this situation myself is I ask the patient to move his head and neck himself. So there's no forced movement. So he will actually limit his things. And what you're looking out for is any increase in weakness or perhaps a Lhermitte's phenomenon. And that's very important to mention in the history and the diagnosis. And I think it's important. I mean, that's what I was alluding to about the trigeminal reflex, is because, as you all know, there are some trigeminal nuclei going down into the upper cervical spine, down to about C2, C3. So there's a high cervical lesion. This may be affected during the injury. So that's very important that people know they know all the cranial nerve nuclei, cranial nerve anatomy. That's what I would just add to this.
Anand, you have localized the junction. Can you tell us is the horizontal level, which compartment is involved?
You missed the last part. Which?
It's a extradural or intradural pathology. What are we dealing with? From the scan examination.
From the history examination, sir, I can say it was most likely an extradural pathology. Because if it would have been any intradural pathology, then the pattern of this sensory loss and the motor weakness would not be symmetric. It would be dissociated type of sensory.
Since it's a
And,
trauma, it's likely to be an extra pathology.
Yes, there is also history.
And also early bilateral involvement of its short span. Investigate this case.
Sorry, sir. I didn't hear.
How will you investigate in this particular case?
So, the suspecting upper eye cervical cord injury and a history of trauma. First of all, I would like to go for a cervical X-ray, AP and lateral views. To look for any obvious fractures or any obvious dislocation. And also would like to go for a lateral C-spine X-ray, both in extension and flexion, to look for instability or dislocation.
Anand, if you are suspecting a cervical injury, you will not ask a flexion extension X-ray.
Right.
All right. The same discussion is going on, but you should not move the neck. So why you will ask a flexion extension X-ray?
I just say that there's one caveat to that. You can do, if you ask for flexion extension X-ray in this situation, it has to be done with medical supervision. So a doctor has to be there holding the head and, asking the patient any change, etc., etc. You can't let a radiology technician do it because they're not capable of assessing the patient properly. So it can be done under guarded situations.
Also,
So ideally should be avoided.
I think in this situation it doesn't add very much. In this acute situation, I'm not just going back on the history and examination. I'm not clear from your summary. How long after the injury did you see the patient? I should have that in the summary.
Yes, after 2 months, sir.
Yeah, I can't see it here. You say you've missed that. So is it 1 month, 2 months, 3 months? That's very important from the point of view of further investigation.
After 2 months, sir.
Yeah.
So
okay, so what was your next step then? What do you do after this then? Do you have any X-rays, MRI scans, or anything to show us?
Yes, sir. This is the X-ray which has been done in flexion and extension. It was done beforehand. It has not been done at our center.
Okay, can you comment on the X-ray?
So this is an X-ray of cervical spine, lateral view showing flexion and extension. In the flexion, we can see there is no any obvious vertebral fracture or there is no any vertebral body dislocations. All the facets appear normal. The disc spaces are also preserved.
Somebody's got their phone on. I'm hearing a conversation.
We will
Yeah,
probably request
I'll
Subhasis if he can mute everyone, and anyone who want to connect can unmute them. Subhasis, are you here?
yes, I'm muting
Please,
everybody.
please
Yeah.
mute everyone.
Yeah, I'll mute everyone. Only
Whoever
speakers
wants
and-
to speak needs to unmute himself and speak.
I have muted everybody. So speaker, please unmute yourself.
Dr. Anand has to talk.
Yes, I have unmuted myself. And sir, so I can see that disc spaces are also well preserved.
So, I mean, basically, is this a normal or an abnormal X-ray?
I comment it's the X-ray seems normal. One thing I am not sure about, but I cannot. But I like to comment that C1 and C2 space while flexion. I think it's too wide.
See, but I think if you look at the what you're looking at is the C1, C2, you know, alar dental gap.
It's
Okay.
ADI.
And what's the gap there?
To measure it on this X-ray, as it was from side.
So it's like it's 1 or 2 millimeters.
Yes.
Okay. Is that normal or abnormal?
So it's normal for adults.
Okay.
Less than 3 mm is normal.
Okay. So how does this fit with your diagnosis then? Have you got C1, C2 instability? Where's the C1, C2 instability on the X-ray?
Doesn't fit.
Yeah. So to me, I would pass this X-ray as a normal X-ray, given his age and everything. No evidence of C1, C2 instability. So it make me think that maybe I haven't got the correct diagnosis. Okay, or there are other diagnoses, and I'd want to get further imaging.
So, what imaging will you do next? Or any other view of X-ray you want to look for to rule out instability? Dr. Anand, carry on.
I'm not sure about if any other view. I don't know about any other found out kind of instability.
So next, what have you done?
What other views are there? You do the CV junction.
When we use our mouth open,
Oh, what? Sorry.
mouth open by keeping the mouth open.
And do you have a mouth open view?
No, sir, I don't have.
Fine. What are you looking for in a mouth open view?
We look at the
What structures will
we can look at the base of the occipito occipito atlanto joints. We can have a better look on the mouth open.
and any other structures? Yes, you can look at the joints, OC1, any other joints or any other bony structure? you would like to see?
You can see the os.
You will see the odontoid in the center.
Okay.
And on sides, you will get the OC1 and the C1, C2 joints.
Yes, you're looking for any asymmetry in the joint
Yes.
space, where there's rotation, whether the dens is midline, all that you're looking for in the open mouth view. And it's very useful, particularly for atlantoaxial rotatory subluxation situations.
Next, what have you done?
Next to build a CT cervical spine.
See, right, just get the top left image, okay? Is the view you would get in a through the mouth X-ray. Okay, that your top left CT scan.
So you mean
This is the view you would
coronal
get.
view?
Okay, so can you comment on that view for me?
Here, from this view, we can see the odontoid. Odontoid in a midline with no obvious fracture, or it's maintaining the atlanto os diameter both side equally, and it's not going up in the foramen magnum. Also, the joints seems to be both side joints seems to be symmetrical and good dislocation.
Can you see any fractures at all?
So I don't see any fracture.
What are the angles, Dr. Anand? You will check. What are the lines in CV junction in normal X-rays we normally see?
So most probably we look for such Chamberlain's line, which extends from the hard palate.
Yeah, all these things you have to comment in X-rays. You an X-ray and a CT scan, you have to comment about all these lines and angles. And what I see, the history and examination, what you did is not adequate to localize the lesion at C1, C2, as everybody has said. So I think you have to take a note, and what are the students here? I don't know how many students have joined. That everybody should take a note that to localize the lesion, this history and this examination is not adequate. You have to comment about the trigeminal nuclei, as Dr. was suggested. You have to comment how to examine the onion spill anesthesia and jaw jerk, a lot of other neurological examinations. So all students have to take a note about that. Okay. Okay, can't carry on. Carry on.
It's like which seems to be normal here. The second we can look for Beckery's line, and the third we can look for Beckery's line. 3 lines are the most which we use. And all 3 lines seems to be normal based on this CT scan.
So there is no fracture or no instability.
Yes. This CT scan we cannot see any fracture or any instability also, because all the diameters are seems to preserve this scan.
I just ask you a question based on this, okay? What's the difference between platybasia and basilar invagination? How would you define the difference?
The basilar invagination and the second one.
Basilar invagination.
Basilar invagination, so it is defined as when the os shifts upward into the foramen magnum, compressing over the lower part of the medulla.
Yeah, because I would say looking briefly without measuring the angles, there is some evidence of some platybasia in this patient because the clivus is very flat. So maybe there's some congenital anomaly to this, but otherwise, I think to me the CT scan is normal. Okay, there's no instability on flexion extension X-rays. Okay, and I don't know, unless we see the MRI scan or whatever, I don't know how you can say this is a C1, C2 lesion. If there's no instability, no bony abnormality at the CV junction, okay, what's your diagnosis at this stage?
Or would you go for any further investigations?
We would like to go for MRI of the cervical spine, CV junction.
Took the images.
Okay, I think it shows the MRI scan.
Can you
see the MRI of the cervical spine with the whole spine screening. The spine screening here we can see the os is butting over the spinal cord using the CSF fluid attenuation. So we can appreciate a mark plan to interval here and there. It seems to be more than 3 mm. There is no any odd changes, there is no intensity changes.
So are there any chord changes?
Sorry, sir. There is no any chord changes. No single intensity changes in the scene.
So it's Dilip here, Dr. Dilip.
Yes.
Dr. Dilip, there is some comment in the chat box. I think I will request our faculties to comment about those questions and comments in the chat box.
Yeah, I've seen, gone through the comments. Most of the comments are already discussed. So our faculties can go through it. If they want to express any thing on those comments, they can speak on that. But most of the comments are already discussed.
You have axial images? Describe these images.
You can see the view of the axial, the cervical spinal cord, and that the third image, you can see the os odontoideum netting over the cord. Using the CSF fluid attenuation anteriorly. And there is no cord intensity is also seen. There is no cord intensity change is present. in the axial cut also.
So do you think this finding is explains the clinical examination?
Doesn't explain completely, sir, but if like since it could be a reducible type of stability which exaggerates on Y flexion.
So if I can just comment there, this, if someone's got grade 3 power in all 4 limbs following an injury, you'd expect to see some chord changes, chord signal change.
Cord looks completely normal.
Exactly. There's no atrophy. There's no evidence of myelomalacia.
Even the
there's no-
knee muscles are also not showing any signs of trauma.
yeah, and so you have to think about whether this to me doesn't explain his symptoms and signs. I'd be concerned there'd be something else going on with him.
So what can be the differential diagnosis, Dr. Anand? I will ask another student, Dr. Mukherjee has joined also. Is he there?
Yes, sir. I'm Dr. Sanju Chatterjee. Yes, I'm here, man. Sir.
Yeah, Dr. Chatterjee, yeah. Can you comment on differential diagnosis? Because clinical scenario and radiological findings are not matching. So what may be the other reasons of this clinical scenario? Quadriplegia and quadriparesis, I think, and other signs and symptoms is not matching with the radiology. So what will be your diagnosis at the end?
Sir, my diagnosis at the end would be some form of atlantoaxial instability only.
No instability we can't see in the CT scan and X-ray, and also there is no cord signal change. So there is no clinical, though radiology is not supporting your clinical findings. So how can you justify the quadriparesis?
Sir, if you look closely on the X-ray of the flexion and extension X-ray, there was a slight change in the ADI measurement. If we can go back a couple of slides. Yes, sir. If you can see on the extension, there is the ADI is below. I have calculated the ADI was below 3, and in flexion the ADI was above 3 millimeters. So I call it Wang classification 1 type of instability of the atlantoax.
Inflection like 3 millimeter. Inflection doesn't look that significant.
I would disagree. I think this is a normal flexion extension X-ray. I think with the amount of deficit he's got, you should see cord signal change. You may see ligamentous disruption on the MRI scan, on the CT scan. Maybe if it's significant, you'd see some loss of centralizations, maybe some rotatory subluxation. All that is completely normal. The joints are completely normal. Everything is completely normal.
Yes, sir.
So I think if you have, what was the management of this patient?
Hello.
Yes,
Can
sir.
I speak?
Yes, sir.
Hello. 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 Can I speak?
Yeah, please speak.
Please.
Yeah.
If you see this flexion extension X-ray, there is a definitely dynamic change. If you flexion the space, ADI is increasing, and in a section it is decreasing. So though it is a very subtle, but patient history.
Sir, you have
Your
got
voice
mute.
is muted.
Sir, please unmute.
Okay, can you hear me?
Yes.
So if you see, in the MRI, So the MRI, please. If you see the MRI, this is the days is curving backward, and there is a definite clinking and loss of CSF space. And also the ADI is also increasing here. So what I guessed actually is probably a transverse ligament injury, and that way little BPN movement is happening over there, because typically the symptoms and signs was uh, uh, correlating with his clinical findings. It was not, power is not 3 plus, patient was walking. It was 4 plus, but patient was walking, it's not 3 plus injury. But yes, he was sometimes having the Lehermitz type of phenomenon. Hoffman side is positive. There is a DTR was increased and patient was spastic. So it was all suggestive of high cervical cord injury. And probably it was a kind of mobile, not fixed one. So whenever he was bending necks, he was having flexing neck, he was having layer kind of phenomena. That was very typical. I examined the patient. Though there is a no quad intensity changes, but at the start when he had an injury, there was a quadriplegia. I don't know what was the cause, because no quad intensity changes here. So what I feel, there's a probably a mobility is there at C1 C2 junction. If you see very closely, and probably a ligamentous injury which is mobile type and causing his problem. So that was my actually perception of this patient, because he was admitted in INK and there he was treated conservatively for few, I think few days, 15 days or something, and then he was advised surgery there, fixation of the C1 C2, and this patient then went to I think
IQ City.
Durgapur IQ City. There he was also planned for surgery. Probably he was taken in the surgery room for OT room for 2 times, and then he was sent back. Different reason, the intraoperative monitoring system is not there, like that. And then he came to me, and though he was 2 months history, he was very spastic. Gait was spastic. Though bladder problem movement was not there, and we very closely I saw his all the symptoms were matching with the C1 C2 junction. So that's why I actually took a risk to fix the this surgery. Next, Dr. Anand will tell. Actually, this case presentation was not supposed to be done. He did not talk to me. It is was a general case, Sewell's AD with myelopathy is a general presentation in the reference, but I don't know, he did not show me all this about this case. This was not a idea of presenting this case. The topic was AD with myelopathy, general discussion. And there we would have a question. I don't know why he's presenting case without my taking permission. So
I
he did.
think this teaching class, I think we should restrict mainly to the history examination and
Yeah, yeah. So
localization.
that was the, actually this case presentation topic was AD with myelopathy, general presentation for everyone. What the students should know in what perspectives. This particular case was in the reference, not as a detailed presentation. For him, it is not possible to answer all the questions. He's just first year, second year student.
For students, the radiology is not that important. Mainly, you
Yes,
have to make a
of course,
clinical.
important. Radiology is there. That's why you can see the MRI. There is a definite gap between the anterior arch and the dens, and thus dens is curving and it is also compressing at the CV junction.
Yes.
But what is expected of residents is to justify the differential or the provisional diagnosis
Yes, yes, that
based
was
on.
actually the idea. He should not have presented this case because it's not for his cup of tea. But, topic was AD with myelopathy general presentation for a student perspective, not this
Right.
case presentation. It is not possible for him to present all these details in AD.
We expect also in an examination that your
Yeah, yeah, it
radiology
was a
will.
presentation. That's why if you would have presented the general thing, we could have given you feedback. So these are the history points to be taken. These are examination point to be taken. Like we are discussing, we have already discussed like cranial nerves, which nerves to be examined, which not, or how to examine the motor nerve, how to sense the nerve. That will be the different perspective. Now we are all focused on this particular case. So it is not his domain to present in this stage of time. So he did not show me all this presentation. Today only evening he sent me presentation. I did not ask to present this case. I told him the topic is AD with myelopathy, general presentation, history, what will be the history, examination, investigation, and how to manage this case.
Now, can I ask a question? Has the patient deteriorated between the trauma and presenting to us? Has he deteriorated?
Which one? This patient?
Yes.
No. This patient, in fact, improved. He was quadriparesis. I don't exactly don't know. He said we don't know the previous history. He did not show us in the paper. But what he says that when he had this injury, he was not able to move his limbs. What was the grade of power? He don't know. Then gradually he said I improved, but there was a residual spasticity along with the neck pain, restriction of neck movement, and Lehermann's phenomenon was positive. There was a DTR was increased, and ankle jerks were changed. All the jerks were decreased. So this was basically patient was spastic, and he was able to walk.
So that was a nice history to present. Like the patient initially presented with significant weakness and then recovered. I would like to ask Dr. Anand or Dr. Chatterjee whether what can be the cause of this type of presentation. Initial presentation with significant weakness and later the weakness improves. And what do you think? Like here we miss the chronology. What do you think? How many days probably the patient has improved? What can be the chronology of cervical spine injury?
Exactly.
Patient could have
If he was advised
due to the trauma.
Conservative treatment at INK, they must be having reasons for that. That is why I want to know what was the
So probably
deterioration or improvement.
At
No,
that
I'm
time,
asking Dr. Anand, why do you think initially the patient had significant weakness and later on the weakness improved? What condition can explain this situation, this chronology?
Due to the sudden injury, patient could have been gone into the spinal shock.
Yes.
So could have caused a complete quadriplegic and then later it recovered.
Yes. So what do you expect the chronology to be? Like in how many days, weeks, or months do you expect the patient to improve?
I think approximately 12 to 14 days will take time to patient to improve.
Very
from
good.
The
And
initial shock.
yes. So how will you identify, like if a patient presents initially with significant weakness and persists to have that weakness over 48 hours, how will you identify whether the shock stage has passed or not? So what is the difference between the spinal shock stage and the cervical injury? I mean, the weakness, significant weakness due to cervical injury. How will you differentiate?
Continue to be a cervical high cervical cord injury. Patient will be having those difficulty in breathing. The respiratory pattern would be deteriorating, and while patient is recovering from his spinal shock, he will not have those respiratory difficulties.
Any other? Yes. Please. Anything else we check in our neurological examination that can differentiate whether the shock stage has passed or not?
Can you explain in spinal shock what is the usual clinical conditions we get on examination?
Examination in spinal shock, sir, we have.
What will be the tone? What will be the other things?
Yes. Tone in the spinal shock, there will be a hypotonia in all the limbs, the initial period.
Then
And
reflexes.
reflexes will be diminished.
Yes.
And in the high cervical cord, there will be hypertonia, hyperreflex.
No, in the shock stage, there won't be any hypertonia. Once the shock stage passes, you will get exaggerated reflexes or spasticity. Any other specific reflex which will help you, which Dr. Doctor is asking you? Have you heard of bulbocavernosus reflex?
Yes.
That is the importance of testing bulbocavernous reflex in all suspected high spinal injury, so that we can determine whether the spinal shock stage is still the patient is in spinal shock or is in injury stage. Very good. Very good.
Anand, I have one question. What is Sciwora?
So what is?
Sciwora, SCIWORA. Have you heard of? Dr. Chatterjee?
No, sir, I have not heard about it.
SCIWORA, Sciwora. I think it comes as a short note also in the theory exam.
Is the acronym Sciwora, SCIWORA.
Have you come across this term?
No, sir.
Basically, it's an acronym for spinal cord injury without any radiographic abnormality.
Okay.
So this case almost is like a Sciwora, because when the Sciwora term was coined, MRI was not there. So it was based only on the X-rays and CT scans. So a lot of these patients, when MRI was done, they were found to have some intramedullary signal changes, which could explain the neurology. Okay. So this no, because it comes as a short note also, and could be asked about in the exam also.
So if we are done, should we move on to the next case? Do you have another case?
No, we have one case probably.
Yeah.
Then we can carry on with
Yes,
this.
sir. We had
Can I just make one comment about this case before we finish with it? Is the fact that I think in this situation, if you're looking for Sciwora, what I would do is a flexion extension MRI scan. And that will show whether or not there's significant compression in the cord. I think there's some congenital anomaly here. Doesn't quite fit in, Chamberlain's line, McCain line. But I think the kinking of the cord is there. But I'm just a bit perturbed by the lack of any signal change. So I think if there's significant compression on the flexion MRI scan, then I would operate. If there's not, then I probably wouldn't operate on him. Any comments?
So I think I have a question. If we go see the imaging based on only clinical scenario, the history and examination, what will be the differential diagnosis rather than atlantoaxial dislocation in these sort of cases? Hello?
Who are you asking? You're asking everybody or just Dr. Anand?
No, I'm asking Dr. Anand that based on the history or examination, what will be the differential diagnosis apart from atlantoaxial dislocation? Is there any differentials, or you will stick to?
We can have a
just from an examination perspective, in your examination, examiner will ask all this.
Yes.
So these are the examination module. So you have to follow the provisional diagnosis, differential diagnosis. How can you localize whether it is intramedullary, extramedullary, or if it is extramedullary, it is intradural or extradural. All this you have to differentiate in your history and examination point wise, that you are thinking it is C1, C2 level abnormality, it is intradural or extradural, and you have to justify your points from the history and from the examination before you see the image. So that is the exam normally happens in MCH or DNB final exam. So I will request Dr. Dilip to see chat box again. There are a lot of questions. If it is
No, a question to
possible.
the House. What do we propose to do with the patient? Apart from further investigation, what do we do with him now?
We operated him and we do the C1, C2 fixes.
The surgery has already been done.
Yes. Yes.
Oh, right.
Okay. So
has his neurology improved?
Yes, my post-operative patient's spasticity reduced. Patient was mobilizing well. He was making a walk very well in the corridors of the hospital. His
Right.
grip was improved.
Very.
So Dr. Anand, Dr. Jarwar is
Yes.
asking in the chat box whether there is any Chiari malformation or not. Will you comment about it? Whether any Chiari malformation or not?
But if there is not any carrying malformation, patient have a mercurial
Yeah, you can see the chat box.
Yeah, my point is, I think he's got a Chiari 0 or 0.5 malformation. Okay, which is why he's got kinking of the cord there. And I think I mean, we're talking specific, fine point here. He deteriorated because of he's got some congenital stretching, whatever, of the cord at that level there. That's why he deteriorated after the injury.
Okay.
This is not a normal cervicomedullary junction.
Okay. And if Professor Anna Goswami Madam is there, so I will request Madam to comment about the anesthetic aspects during surgery.
The voice is breaking.
Well, anesthesia, the main time during the anesthesia is the duration which takes to intubate this patient. You have to do without minimal movement of the atlantoaxial junction, which is quite a difficult proposition for an anesthetist. There was a time when we were using the short-acting muscle relaxant called scoline. Now, due to various reasons, it has fallen into disrepute, and we have to take resort to the longer-acting. Actually, it is not necessary that we take resort to it, but the standard practice is to keep the equipments necessary for difficult intubation at hand. If you have a video laryngoscope or if you have anything which will prevent you from a smooth intubation should be ready at hand. And there was a time when Dr. Manoj Bhattacharya and Professor R.N. Roy started these atlantoaxials way back in the 1981-82 period. Then all these were not around, and we had a very, very difficult time. And we used to do the wake-up tests, After intubation, one wake-up test. After positioning the patient on the table, we had the second wake-up test. And after the fixation, then they used to put these contour rods, and fix the junction. So after the fixation, that was the last Stagnara's test, we used to call it. And the entire procedure of anesthesia was a real headache for an anesthetist. But life has become very much easy with easier forms of surgery, better equipment, better intubation techniques, and I can only thank the modernization of our profession for helping us. That is my comment so far as a
So, is there any neurologist here? Any neurologist still here?
Your voice is cracking.
No, is there any neurologist here? Neurologist. Is Dr. Dilip here?
Yes.
Dilip,
So
we
I
still
was,
cannot explain. Somebody is asking in the chat box. We still cannot explain the neurological clinical scenario by the imaging. So, is there any neurologist colleague is there who can comment on it? Is Dr. Gunjan here? Hi, hello.
Yes, I'm here.
Dr. Gunjan,
Yeah,
so this clinical scenario we can't explain by the imaging. So what can be the other causes of this neurological, as a neurologist, how will you look at it, this case, as a student who is examining?
I think.
What is your?
No, I think what I believe is that we have to go retake the history and probably re-examine the patient, because the thing is that what we are trying to do is we are trying to fit the imaging and the clinical thing. So probably maybe there are some other clinical clues or something which can be there. So unless the examination part is done, maybe there can be some other clues which we can go back and then we can assess the patient and then try to localize it and correlate with the imaging findings. Probably that would be my approach, what I would think in this. Yeah. So it will be very difficult for me to comment based on this only and what we are seeing over here. Because initially it took like a straightforward case of maybe a CV junction. There was a history of fall. There was other things, but then now I think it is probably probably now we need to go back and relook at what the history was there and the examination part and other things is there. Yeah. Hello.
Yeah,
Hello.
see, I agree with that. I think this is not a straightforward. I
Yeah, others
Can
may
you hear me?
also comment
I've
on
been
this.
postulating. Yeah, I've been postulating this. He's got some congenital anomaly here. Okay. And with the differential diagnosis, to me, we talk about this. He may have had some pre-existing condition, which was exacerbated by the fall. And I think in this situation, you need to do a flexion extension cervical spine MRI scan to see if the cord compression is accentuated in flexion. Because radiologically, to me, there's no evidence of any instability. The thing I would say is, in fact, if you look at the relationship of the arch of the atlas to the tip of the dens, there's actually too much of the dens sticking up above it. So I think there's a congenital anomaly here.
Was there any history of short neck or anything like examination and then?
Yes, impossible.
Has he got low set ears? Where does his neck start? Has he got fat neck, thick neck?
No, he was a moderately built guy with no short.
Like, what is the definition? Like, what do we do for short neck? What all do we? How do you say it's a short neck or this?
Well, I think it's what I call is low set ears, with the hairline, the neckline is lower.
Yes,
You know,
sir.
is lower than you'd expect. It's not a very scientific definition,
Yes, sir.
but
Actually, there are some measurements also, but I don't think they have been really like we do some measurements and all based on the
yeah.
height and other things. That's what we've been taught. But yeah.
Yeah.
I think others can also comment. Others can also say in the comment box. And
Yeah, there is a question in the comment box. But if flexing was causing an issue, then when it is extended. So,
See, hi, Christopher. I am Dr. Singhania speaking. Hello.
yes, sir, we can hear you. Yes.
Yeah, see, if we will see carefully the MRI, which is showing there is a odontoid has been placed posteriorly, it's impinging the cord. And if you will see the ligament has been stressed. So here we have to understand maybe some congenital anomalies or there is a subtle instability. So Christopher was right, we should do the flexion and extension MRI and we should see the cord compression. And we should know the pathophysiology, because if we understand the pathophysiology with the repeated movement of the cord, there is a axonal injuries and might be that is the cause of his weakness, and that has to be deal with this either the surgical correction or it's a fixation. But yes, first we have to do the diagnosis, and flexion extension is one of the options that I will tell.
Yeah, that's my point.
Yeah, because
Yeah,
there is a clear cut here. If you will see that the anteriorly the cord is impinging with the odontoid, so it's not a normal MRI.
Yeah, I think if I enlarge the image, I think there may actually be some medullary thinning. If you enlarge the image, the second image down on the left, there is actually some wasting of the cord there. So I think this is a chronic. This is a chronic. If this image, I can't. Can I write on here? I can't. How do I? Can I write something here? If I just here annotation here.
And if you will see, there is a subtle intensity changes. If you will see carefully.
Yeah.
So, yeah, anteriorly, if you will see, there is a subtle intensity changes is there. So it's a repeated cord injuries due to the flexion and extension, and that lead to it's a pathophysiology that leads to the neuronal injuries, and due to the stretching, it's causing the neurological deficit.
Yeah. See, I suspect this chap wasn't normal before the accident. He maybe had some subtle symptoms and signs.
Right.
But I think he'd have had problems before this, and the injury caused the exacerbation.
Most likely, yes.
Sir, is there any role of DTI scan in this? Because we had a study with DTI scan to see the subtle injuries. So
I don't know about the DTI. DTI is it diagnostic for the spinal injury? I
yes,
have
sir.
no
I think
idea.
there is a lot of literature now is coming when the normal MRI is normal, but there
This
is a
MRI
clinical.
is not normal. This MRI is not normal. Yeah, we
No,
cannot
it's not
say it's a
normal.
normal
But
MRI.
also it is looking at MRI at the first chance, that everybody, I think most of the radiology and people will think that there is no signal intensity. So
No, there is a subtle
No,
intensity changes if you will see carefully. There is a buckling of the cord, there is a subtle intensity changes, there is the
actually,
posterior lying odontoid. So it's
uh,
not a
dense,
normal MRI.
dense is impinging on the CB junction. It is very clear cut. I also discussed with my
yeah,
radiology. So they also have an opinion that there must be some ligamentous injury, or it is a pre-existing thing which has aggravated during the injury, and then the residual effect is still there. So I had no option but to try and fix it. And after fixation, there was a dramatic improvement. Patient had significant, around 50 to 60% improvement in his clinical uh, picture. So grip improved. He started walking. His
probably
spasticity
a
had gone.
dynamic compression.
Yeah,
To
so
make it.
probably I could have done this. In this case, could have done a dynamic MRI to demonstrate or illustrate the better. But based on his clinical picture, trauma, gradual improvement, probably he was in spinal shock initially, and then he's improved. But probably he was having a repeated injury, because whenever he was flexing his neck, there was a typical Lehabit's phenomena. That was very, very classical in this patient.
That should have been brought up in the history.
Yeah, I don't know. Actually, he did not
Yeah,
told me
that's
about this.
it's all. I think it's
He
very
did not.
important.
He did not ask me that he's presenting this case. What I was an impression that it was a general discussion on AD with myelopathy in reference to history, examination, investigation, and mode of treatment. So I was not aware that he's. Otherwise, I could have. I could have. I asked him to prepare in a better way.
No, I
So
think
is
we're
Dilip
all.
here,
So,
moderator?
so I think we're all agreed it's a very good, very interesting case.
Yeah, it is very interesting.
Can I
Because
ask what is DTI? You just mentioned
diffusion tensor
DTI,
imaging.
diffuser, yeah, DTI, diffuser tensor imaging. That is the tractography. Tractography. In
MRI.
tractography, we
Yeah,
can
yeah.
see
See
clearly
the
which
fibers.
tract is there and is
With
there
the
is
same
any
with the
disruption.
same machine, with the same MRI
Yeah, yeah,
machine.
MRI machine. It is basically done in the brain to see the tract before the surgery.
Uh-huh.
Thomas, tumor surgery you have to do in DTI to see
Exactly.
it over the can
Tractor.
So same kind of fibers we can see, or the small minor changes can see in the white
Acha,
matters.
acha.
That is.
Right. Thank you.
So, Dr. Dilip, if there
Yeah.
is, I think time is there, so we can conclude. If there is no other question in the chat box, we can see it.
Yeah,
Then you can conclude.
we have already discussed the questions that were asked on the in the chat box about bulbocavernous reflex, that it is the first reflex to reappear after spinal shock. We have already discussed that pectoral reflex will be helpful to identify high cervical like C1, C2 injuries. And we have discussed about syrinx. We have discussed about Chiari. So we had a very nice discussion on vertebral junction. I congratulate both the presenter. I also congratulate all the faculties and everyone who joined with us for a very nice discussion. So should we conclude?
Yeah. Thank you.
Yeah, thank you. It was a great case. Lots of discussion. Very interesting. And not my patient.
No, sir, he was admitted under INK. I don't remember. Still, I don't remember that.
I never saw the patient, so I don't. I think
Okay, he was there.
I would have operated, I think, if I'd have seen this patient.
Yeah, he was there for 2 weeks. That's what he told me.
Yeah.
He was there for 2 weeks, and because of this, this MRI and everything was done there, I think. So because of this dilemma, there is no clear cut of radiological evidence correlating with his clinical findings. So that's why probably surgery was deferred and giving him a chance for conservative management. And to with conservative, he improved quite significantly. But later, he was all the residual signs and symptoms were there. So then we decided to go for this.
Yeah, no, he's done well actually. He's improved after surgery, so you've
Yeah,
done
his
the right
dramatic
thing.
improvement. His grip
Yeah.
became his grip was very weak. He was very nicely. He started having the grip power, spasticity gone. He wanted his pain was gone. He was definitely having pain or movement. So in during flexion, Lehermit's phenomenon was very classical in this case. So that's why I thought it must be some kind of instability and mobility at this region.
Yeah, good, great,
Thank
great case, great case.
Other symptoms.
Okay,
With
Dilip, I think you can conclude.
Yes, we
Yeah.
conclude this case discussion. For the residents, the take-home message should be with
Detailed study.
at the end of the case presentation, at the end of the history, at the end of the examination,
Yeah.
you will present in such a manner that you will be able to localize the level, the vertical level, as well as the horizontal, the substrates that are involved. So you should be able to differentiate between low cervical, high cervical, and CV junction, like the pectoral reflex which was asked. You will be able to differentiate between extradural, intradural, and intramedullary pathology. And also you need to come to a provisional diagnosis. You need to have some differential diagnosis, points for and points against your all the differential diagnosis. And then you need to confirm it with the radiology, and there should be discussion about the radiology. So thank you all. It has been a very nice discussion. So we'll look forward for such discussions again in your future. Thank you.
Thank you.
Good night,
Thank you.
everybody.
Good night.
Good night.
Good night. Good night.
Thank you all. Good night.